Welcome to HCC's webinar on private insurance. This is part of a series that we're doing all year that's covering health access, health advocacy, and health policy to help patients be able to better access resources and advocate for themselves. Today, our speaker, Michelle Rice from NHF, will outline changes coming to private insurance, as well as both standard private insurance and self-funded plans through employers, resources for patients, and opportunities for patients to advocate for themselves. I also want to take a moment to thank the sponsors that are supporting this series this year, Takeda and Sanofi Genzyme. Thank you so much for supporting our program. So with that, I will turn it over to Michelle.
Well, hello, everyone. I've been asked today to speak to you about commercial health plans, whether those be fully insured or self-insured, and what are some changes you can expect to see and how those may impact you. To take a step back, I am Michelle Rice. I am the Chief External Affairs Officer for NHF, and as you may or may not know, we have a team of folks that work quite closely with payers across the country and at the various state and federal levels. So the first thing I want to talk to you about is understanding how you're covered and why that matters. Healthcare coverage can be private or public. And private covered plans, and the reason why this matters, let me again take a step back. The reason why it matters is depending on how you are covered, depends on where you go to receive help when you have questions or when you have complaints. So for example, private and fully insured employer plans, when you have concerns or questions that you don't feel are answered by the health plan, the place you go to get additional help is the State Department of Insurance. For self-insured employer plans, or sometimes they're called ERISA plans, those are plans where the employer is actually the one paying the cost of care. They pay a third-party administrator, or they pay another health plan like an Anthem, an Aetna, a Blue Cross, to use they pay them to use their network and for them to process claims on behalf of the employer, but the employer themselves is actually paying for those claims. So if you're on a self-insured plan and you need assistance or have an issue with your plan, then you go to the Department of Labor. Public plans such as Medicare or Medicaid, you go directly to those agencies. Just to kind of level set, I wanted to explain how nationally the population is covered, how they receive their health insurance. So across the U.S., about 9% of patients are uninsured. 1% are kind of other public, that may be, VA plans, tribal plans. There's about 14% on Medicare, 21% on Medicaid, and 7% on non-group. If you look at how California is covered, they actually have a lower uninsured rate, so 7% are uninsured. The other public and non-group are very similar, as is the employer. But what you will see is the Medicaid rate is higher than the national average, and the Medicare rate is a little bit lower. Now, this is for the general public. And what I would say to you is that nationally, if you pull together all of the people with bleeding disorders or people with hemophilia, we're fairly close to what you see here as far as numbers, as far as to how people are insured, although I would say that we have a relatively small population of uninsured. That is much lower than 7% in the hemophilia space. What is different for you, particularly in California, is because of your GHPP program, some of your other programs that are offered through your state Medicaid program or Medi-Cal, there is a larger percentage of patients in the state of California with bleeding disorders who receive their insurance through the state. So as we all are painfully aware, healthcare costs continue to rise. And not only is the cost for us as consumers higher, and we see that in our premiums, we see that in our copays, but the cost for the purchasers of healthcare is also continuing to rise. And when I say purchasers of healthcare, the reason I'm saying that is we think of health insurance plans, but also we need to think of employer groups because, again, they are the ones who are actually purchasing healthcare. We are typically purchasing our healthcare through one of these other groups. So what are payers doing? What are purchasers of healthcare doing to try to address these rising costs? Many of them are starting to manage their spend through the implementation of something called utilization management. And utilization management has been around for quite a while. It's a technique or series of techniques used to achieve improved outcomes at the lowest possible cost. And these techniques can be applied to both the pharmacy and the medical benefit. They are fairly new in the hemophilia space, and we'll talk a little bit about that on the next slides. So let's talk a little bit about what the difference is. So medical utilization management, this usually has to do with the medical coverage under your health plan. What are some ways that, payers are utilizing this technique is the creation of, or the increase in the number of high deductible health plans, which tend to increase patient out-of-pocket costs. You'll often hear us say that if, for people with a chronic illness that's expensive, like hemophilia, we typically will say a high deductible health plan is not really beneficial to you. While it may give you a lower premium, you are going to have some very large upfront expense that has to be paid the first week of the year. Another example of medical utilization management is prior authorization or approval versus and includes pre-certification. If you're going in for, a surgical intervention, if you're going in for an MRI, even an X-ray these days, you may be required to either get a pre-certification or a prior authorization before you can do that. The use of preferred provider networks, that is not new. We've had preferred provider networks for quite some time. And basically what that does is if you go to a preferred provider, then usually your cost share is lower as an individual. One of the increases we're seeing is site of care networks. So in other words, it's dependent on, it may be a specific type of facility. So like the Cancer Centers of America or a hemophilia treatment center or, a pain clinic. So it will be if you go to certain site of care facilities, you may get a lower cost share. The other thing that we are seeing is an increase in requirements around medical necessity statements from your clinicians for when you're going to get either procedures, tests, or lab work done. You're also going to see that they may require that you go to certain facilities to actually get those labs done, which a lot of times can be a burden for people with bleeding disorders because sometimes while they may allow you to see a hemophilia treatment center, they may not allow you to get your lab work done at the center. So what we found is that with medical utilization management, one of the unintended consequences of some of these techniques is surprise billing for the insured individual. So let's say I'm required to go to a certain facility to obtain my lab work. Well, that doesn't necessarily mean, or let's say my imaging. So let's say I get an x-ray done. Just because I went to that facility doesn't necessarily mean that the radiologist later who reads my x-ray is contracted with my health plan. So then as a patient, I receive what is referred to as a surprise bill. Because that person may be out of network, all of a sudden I find out I have a higher cost share. There are a lot of bills kind of floating around in Congress and at the local levels to try to address surprise billing. But we will keep you updated on that. One thing I will tell you is that if it is an emergency that you're going into the hospital for, if you're going into the emergency room, most health plans do not allow for surprise billing. What happens then is, even if it's an out-of-network provider, if it's an in-network hospital that you're going to, or if it's an emergency situation, they will treat all providers related to that visit as being in-network. And there's pharmacy utilization management, which I think we are all becoming in this community much more familiar with. In the past, clotting factor was covered probably 90% of the time as a major medical benefit. As insurers have looked to try to control their costs, and as they've looked at how many patients are doing prophylaxis, how many patients are doing self-infusion, they've started to transition the coverage for clotting factor from the medical benefit over to the pharmacy benefit. For a couple of reasons. One, it is easier for them to track when it's in the pharmacy benefit. Two, they have the ability to have a much more narrow network within a pharmacy contract. They typically utilize prior authorization more. They also will utilize what we refer to as formulary management, where they decide which drugs will be covered, which drugs won't. They may also implement preferred drug lists, which those lists are actually all of the drugs that are covered, but it takes it one step further and says, here's the drugs we'll cover at this price, here's the second tier drugs, here's the third tier drugs, and in some cases, here's the fourth tier drug. Typically, your first tier is your generic, your second tier is your preferred, your third tier is your non-preferred, and your fourth tier may be a specialty pharmacy or a specialty drug. So basically what that does is allows them to charge different copay amounts to each one of those tiers. The other thing that we have seen is something called step therapy edits. This is something we, to be honest, never thought we would see in hemophilia because we didn't have this problem when this first came out. And what a step therapy edit is exactly what it sounds like. You can't access this drug until you've tried this drug first and failed. Often the reason we thought that we would not have to deal with those is because, you know, what is the definition of failure? And since we thought that it was a very difficult thing to define, we didn't think we would have these problems. We are finding them more often. I will tell you there are several states who have passed legislation that limit the type of step therapy that can be done, or in some cases have eliminated it altogether. Another big change under pharmacy utilization management is the patient reporting requirements. This may mean you have to provide logging information. It may mean you have to show that you have, you may have to show when you've had a bleed. You may have to prove how much product you have on hand. These are some of the new things that many of us in the hemophilia community are having to deal with. And then, of course, the one that has really become very apparent in this community in the last couple of years was the copay accumulator adjustment programs. These were the programs where it was decided that you could use your manufacturer's copay card, but the amount that the manufacturer paid towards your copay or out of pocket no longer counted towards your copay or out of pocket. Many people found themselves over the last couple of years being surprised with, well, now you've used up your copay card, now you yourself have to pay your $6,500 deductible and out of pocket. And the last one on the list is quantity limits. We don't really see this much in hemophilia, but this is where if, let's say you're taking a pain medication or a heart medication or some other type of medication, they may say you're limited to only 30 pills in a 30-day time period or 60 pills in a 30-day time period. Again, these are all things designed to help lower costs for the payer. I just wanted to show this. You know, in the hemophilia space, we've often had to get prior authorizations for clotting factor. However, the process was much simpler than what it is now. What I mean by that is previously a physician might have to, at the beginning of the year, say, I have a patient who's diagnosed with hemophilia A, severe. Here's their date of birth, here's what they weigh. Here is the product that we're going to use to treat them, and we're going to treat them 3 times a week. All they really needed to say was the diagnosis, the severity level, and then state the product they wanted to use. And that was typically once a year. What we've seen over the past couple of years is them starting to add different layers to that. Now it may be that they have to submit this information quarterly instead of yearly. The big change is that because our drugs have started to be included on preferred drug lists, as I said earlier, here's the preferred drug, here's the non-preferred drug, or this drug is non-formulary. Now the physician is having to provide more information. We're having to say, why do I want this patient to be on a non-preferred drug instead of a preferred drug? Why can't they try that one first? The other thing that's having to be reported is there's an increasing request from health plans to supply treatment logs. There's also an increased requirement on behalf of the specialty pharmacy or the 340B program to find out how much product a patient has on hand before they ship them additional product. So I wanted for you to see this just because this has become a sometimes lengthier process than it's been in the past, and a more frequent process than it's been in the past. So you may see your physician asking you mid-year, have you, gained weight? Can I have a new, weight for you? Part of that is probably because they're having to renew their prior authorization. The good news is I mentioned earlier about these accumulator adjustment programs, and these programs were no longer allowing any of the manufacturer assistant programs to count towards a patient's deductible or out-of-pocket maximum. NHF was very involved in advocating to get these programs removed over the last couple of years. And thankfully, in April of this year, the Center for Medicaid and Medicare Services, CMS, issued a rule that said, if a generic is not available for a particular drug, the manufacturer's copay card must count towards the patient's deductible and out-of-pocket. Well, as we all know, in hemophilia, we do not have generic drugs. So therefore, effective 1/1 of 2020, as the rule stands now, manufacturers' copay cards would count towards patients' deductible and out-of-pocket for clotting factor therapies.
Thank you so much. And thank you again to Takeda and Sanofi Genzyme for sponsoring our 2019 webinar series. Thank you, Michelle.